Welcome to this audiobook entitled Lower Respiratory Tract Infections. As a way of introduction, lower respiratory tract infections were the fourth most common cause of death globally in 2010, according to Lee 2016b. In addition, lower respiratory tract infections are responsible for around 600,000 hospital visits and 900,000 outpatient visits per year, resulting in $10 billion to $17 billion in healthcare costs, according to Lee 2016a and Kazan 2016. This chapter focuses on recognizing, diagnosing, managing, and preventing lower respiratory tract infections, with an emphasis on bronchitis and pneumonia. Next we will discuss types and management of infections. Let's begin with bronchitis. Acute bronchitis is a self-limited respiratory inflammatory process that is associated with a cough lasting less than 3 weeks in the absence of infiltrates on chest radiography, according to Walsh 2010. In contrast to bronchiolitis, bronchitis is a disease of the large and mid-sized airways. Chronic bronchitis is predominantly associated with smoking and chronic obstructive pulmonary disease, abbreviated as COPD, and is defined as chronic mucus production for at least 3 months for 2 successive years, according to Martin 2015, and Punchurieri 2010. Next we will discuss its epidemiology and etiology. 5% of people in the United States report physician-diagnosed acute bronchitis annually, with the highest incidence during the winter months, according to Walsh 2010. Acute bronchitis is caused by viral pathogens 90% of the time, including rhinovirus, enterovirus, influenza, parainfluenza, coronavirus, human metapneumovirus, abbreviated as HMPV, and respiratory syncytial virus, according to Kincaid 2016. Influenza, parainfluenza, coronavirus, adenoviruses, HMPV, and respiratory syncytial virus cause infection throughout the winter months, whereas rhinovirus, which may cause infection year-round, tends to increase in prevalence during the fall and spring for unknown reasons, according to Walter 2017, Walsh 2010, and Aruda 1997. 10% of acute bronchitis infections are caused by bacteria. Mycoplasma pneumoniae, Chlamydophila pneumoniae, and Bordetella pertussis, the most commonly identified bacterial pathogens, can cause infection year-round, according to Kincaid 2016, and Walsh 2010. Chronic bronchitis is often associated with exposure to inflammatory stimuli, including cigarette smoke or infectious agents, according to Martin 2015. With persistent bacterial bronchitis, infection develops once invading pathogens, i.e., Haemophilus influenza, Streptococcus pneumoniae, develop biofilms within the airways, leading to chronic inflammation, according to Ashok 2017. We will now discuss its pathophysiology. The pathophysiology of acute bronchitis is not well defined, especially for non-viral etiologies, according to Walsh 2010. An autopsy series compiled from 47 children found that the cytopathology of influenza consisted of submucosal congestion, mononuclear cell infiltration, epithelial necrosis, and hemorrhage, according to Walsh 2010. Examination of adults resulted in findings ranging from mild inflammation to desquamated necrotic debris. Respiratory syncytial virus has been shown to infect the terminal bronchiolar lining in infants, but this information is lacking in adults, according to Walsh 2010, Fulci 2000. Finally, rhinovirus has been shown to cause patchy infection of bronchial epithelial cells, according to Walsh 2010. Although the specific disease cytopathology is not well described outside influenza, respiratory syncytial virus, and rhinovirus, host immune response is a vital component of the disease pathology. Cytokines and chemokines released in response to the infecting viral pathogen lead to inflammation, resulting in the symptoms associated with acute bronchitis, according to Walsh 2010. In addition, release of these pro-inflammatory cytokines resulting in inflammation leads to prolonged airway hyperreactivity, according to Walsh 2010. Among the bacterial pathogens, Bordetella pertussis is thought to uniquely release a toxin that is partly responsible for the prolonged cough, according to Walsh 2010. Next we will discuss its clinical presentation. Acute bronchitis is a clinical syndrome predominantly composed of cough, nasal congestion, sore throat, sputum production, dyspnea, headache, malaise, and low-grade fever, according to Kincaid 2016, and Walsh 2010. Persistent fever, temperature higher than 100 degrees Fahrenheit, is uncommon after the initial days of illness, according to Kincaid 2016. With some pathogens, patients may also have chest wall pain or chest discomfort with coughing, Walsh 2010. Symptoms can last for 7 to 10 days in mild cases but for up to 3 weeks in others. Persistent cough is not uncommon and is the primary reason for physician visits associated with acute bronchitis, according to Kincaid 2016. In contrast, cough and mucus production with chronic bronchitis lasts longer than 3 months. Regarding its predisposing factors, older age, specifically frail older adults, comorbidities including cardiopulmonary conditions, immunosuppression, and environmental exposure to irritants such as second-hand smoke can increase the severity and duration of illness in patients with acute bronchitis, according to Kincaid 2016. Regarding its diagnosis, a detailed medical history helps rule out other causes of persistent cough, including asthma, COPD, pneumonia, upper respiratory tract infection, and heart failure, according to Kincaid 2016. Patients should be asked about environmental exposures, travel history, and sick contacts. Vaccination status is useful but does not rule out pathogens such as influenza and pertussis, regardless of previous receipt of vaccines against these pathogens, according to Kincaid 2016, and Walsh 2010. Physical examinations will add valuable information to accurately diagnose infection. The primary goal of the physical examination is to rule out other causes of cough, especially pneumonia, according to Walsh 2010. Lung auscultation in acute bronchitis may reveal wheezes and rhonchi that improve with cough. Signs such as decreased breath sounds, bronchial breath sounds, crackles, egophony, and fremitus should be further evaluated, given that these are of concern for pneumonia, according to Kincaid 2016. Laboratory testing is generally not useful to definitively diagnose bronchitis, but it may help rule out other causes of illness. Standard laboratory tests like WBC and inflammatory markers are not discriminatory to acute bronchitis. More specific tests like rapid flu or respiratory syncytial virus swabs, PCR for bacterial or viral pathogens, or urinary antigens to rule out common causes of pneumonia may be useful, but these are typically not required or necessary in ambulatory patients, according to Kincaid 2016, and Walsh 2010. Although data are conflicting on the usefulness of procalcitonin in bronchitis, procalcitonin may help discriminate viral from bacterial causes, according to Kincaid 2016. Vital signs are recommended, given that patients with normal vital signs typically do not require chest radiography because the risk of pneumonia is low in the absence of other risk factors, according to Kincaid 2016. Patients presenting with dyspnea, bloody or rust-colored sputum, pneumonia-like findings on auscultation, or abnormal vital signs should undergo chest radiography, according to recommendations from the American College of Chest Physicians, according to Brahman 2006. Regarding its pharmacologic therapy, treatment of acute bronchitis is based on symptoms, with supportive care as the mainstay of therapy, as shown in Table 1:1. Antibiotics are prescribed in 60% to 70% of patients but provide no benefit to most patients because the cause is usually viral. As a result, antibiotics are not recommended unless a specific bacterial pathogen is identified, especially in otherwise healthy individuals, according to Kincaid 2016, and Walsh 2010. A Cochrane database systematic review showed that administering antibiotics results in no difference in clinical improvement at follow-up, even if antibiotics initially improved symptomatology, i.e., decreased cough duration and allowed for increased activity about 1/2 day sooner, according to Kincaid 2016, and Smith's 2014a. Unnecessary antibiotic use can result in bacterial resistance, adverse effects, and increased healthcare costs. Clinicians should be trained to limit antibiotic use, when possible. Over-the-counter medications such as antipyretics, antihistamines, decongestants, and expectorants are often used for symptomatic relief from acute bronchitis. However, studies evaluating these agents are inconclusive, according to Kincaid 2016, and Walsh 2010. Ibuprofen was associated with slightly better symptom severity reduction than acetaminophen in one study, but patients who took ibuprofen also were more likely to have non-resolving symptoms, according to Little 2013. A Cochrane database systematic review found that in studies with antihistamines and decongestants, patients are more likely to have adverse effects when such agents are used in combination, without significant improvement in cough when used either in combination or alone, according to Smith 2014b. In contrast, dextromethorphan and guaifenesin have shown some benefit in trials. Dextromethorphan decreased cough counts by 19% to 36% compared with placebo in several trials, according to Pavese 2001, Lee 2000, and Parvez 1996. Guaifenesin decreased cough frequency and reduced sputum thickness significantly better than placebo and improved cough severity and, in another trial, decreased cough frequency, though not significantly, according to Albrecht 2012, Kuhn 1982, and Robinson 1977. In patients younger than 2 years, the FDA recommends avoiding any cough or cold product that contains a decongestant or antihistamine because of serious and life-threatening adverse effects, according to the FDA 2016. Since that warning, manufacturers have relabeled these products as "do not use in children under 4 years of age." Information is limited on herbal or other alternative therapies, often including echinacea, zinc, and eucalyptus oil, so these therapies are typically not recommended. However, compared with no treatment, honey decreased the frequency and severity of cough in children older than 1 year and may be a viable alternative to dextromethorphan in patients, according to Oduwale 2014. Nevertheless, because of the possibility of contamination with pathogens such as Clostridium botulinum, honey should not be used in vulnerable populations, including children younger than 1 year, frail older adults, and immunocompromised individuals, according to Miguel 2017. Prescription medications such as antitussives and beta-2 agonists have also been used for symptomatic relief of acute bronchitis. Narcotic antitussives, specifically codeine, have no benefit for cough. Codeine is not recommended by the American College of Chest Physicians and should not be used for bronchitis, according to Brahman 2006. In one study, benzonatate was evaluated as a non-narcotic antitussive for bronchitis, according to Kincaid 2016. Compared with placebo, benzonatate did not improve cough when used alone, however, it did improve cough when combined with guaifenesin. Beta-2 agonists have not routinely been shown beneficial in children age 1 to 10 years for cough outside asthma-related cough and thus are not routinely recommended, according to Kincaid 2016, and Becker 2015. In adults with wheezing without asthma or COPD, beta-2 agonists may help manage bronchitis because the benefit of treatment may outweigh the risk of adverse events. Pause the video and carefully scrutinize Table 1 to 1 summarizing the treatments for acute bronchitis. Pause the video and carefully scrutinize Table 1-1 summarizing the treatments for acute bronchitis. Next we will discuss community-acquired pneumonia, abbreviated as CAP. Community-acquired pneumonia (CAP) is acquired with minimal or no recent healthcare exposure or contact, usually less than 48 hours since hospital admission and without residence in a long-term care facility, according to Latvia 2006. Regarding its epidemiology and etiology, community-acquired pneumonia is one of the most common infectious diseases, with an incidence of 1.1 to 1.7 per 1,000 individuals, according to Lee 2016b. CAP predominantly affects those 5 years and younger and those 65 years and older, according to Prina 2015. In these groups, the incidence increases to 9.2 and 33 per 1,000 person-years, according to Kazan 2016. Mortality ranges from less than 1% in patients not requiring hospitalization to 50% in patients requiring intensive care, according to Prina 2015. Although a causative agent is identified in only 30% to 40% of patients with CAP, 5 organisms are responsible for most cases, according to Kazan 2016. Streptococcus pneumoniae is the predominant pathogen that is responsible for almost 30% of CAP cases worldwide, according to Prina 2015. Haemophilus influenza is responsible for 12% of CAP infections, and the atypical bacteria, including Mycoplasma pneumoniae, Legionella pneumophila, and Chlamydia pneumoniae, are responsible for 22% of cases, according to Prina 2015. Other causes of CAP include viruses, Pseudomonas aeruginosa, Enterobacter species, and Staphylococcus aureus. In children, CAP is caused by many different pathogens. Respiratory syncytial virus and other viral pathogens have been documented as the cause of CAP in up to 80% of children younger than 2 years, according to Bradley 2011. Community-acquired pneumonia caused by atypical pathogens occurs in up to 25% of older children. Although Haemophilus influenza and Streptococcus pneumoniae still cause CAP in children, vaccination has decreased the incidence, according to Bradley 2011. Regarding its pathophysiology, microaspiration of secretions contaminated by the microorganisms that colonize the naso or oropharynx is thought to cause lower respiratory tract infections, according to Prina 2015. Natural mechanisms exert protective effects against infection in the respiratory tract, thus, the success of microaspiration resulting in infection depends on the virulence of the infecting agent, inoculum size, and state of the immune system, according to Alcon 2005. The effect of inoculum size on severity of illness has been most documented with pneumococcal pneumonia, according to Camberlin 2015, and Rello 2009. Regarding its clinical presentation, patients with CAP typically present with cough, dyspnea, fever, pleuritic pain, and malaise, according to Kazan 2016, and Prina 2015. Although symptoms are similar across the main pathogens associated with CAP, pneumonia caused by atypical pathogens is often subacute or indolent at the onset of illness, according to Sharma 2017. In addition, some of the atypical pathogens may present with additional signs or symptoms. Patients with Legionella pneumophila can also present with headache, confusion, hyponatremia, and diarrhea, according to Prina 2015. Patients with Mycoplasma pneumoniae may present with skin symptoms, Stevens-Johnson syndrome or erythema multiforme, cardiovascular symptoms, cardiac thrombi or Kawasaki disease, or hemolytic anemia, according to Sharma 2017, Waterer 2017, and Prina 2015. Both Mycoplasma pneumoniae and Chlamydia pneumoniae may initially present with upper respiratory symptoms, according to Waterer 2017, and Prina 2015. Regarding its predisposing factors, risk factors for CAP include alcoholism, aspiration, smoking or a history of COPD, exposure to pathogens through farm animals or birds, HIV infection, recent travel, and sick contacts, as shown in Table 1 to 2, according to Kazan 2016. In addition, recent evidence suggests that individual genetic factors predispose individuals to CAP, according to Prina 2015. In one study, patients with polymorphisms in mannose binding lectin and L-ficillin, both activators of the complement system, were at increased risk of CAP caused by atypical pathogens and Coxiella burnetii, respectively, according to Van Kempen 2017. In other studies, single nucleotide polymorphisms in FcY2 receptors, toll-like receptors, tumor necrosis factor, abbreviated as TNF, interleukin IL-6, and surfactant proteins have been associated with risk of pneumococcal bacteremia, Legionella pneumophila, poor outcomes, and poor prognosis, respectively, according to Ferrer-Aguero 2014, Martin Loches 2012, Yuan 2008, Kinder 2007, Horn 2003, and Waterer 2003. More research is needed in this area to determine whether these genes represent future targets for therapy. Regarding its diagnosis, similar to bronchitis, a detailed medical history and physical examination provide valuable information in the diagnosis of CAP. Physical examinations should include lung auscultation and percussion as well as vital signs and lung imaging. Common vital sign abnormalities and physical examination findings in pneumonia were described earlier. Chest radiography has been the imaging of choice to diagnose pneumonia because of its ease of use. However, chest CT is considered the gold standard because of an increased accuracy compared with radiography, according to Prina 2015. Recent evaluations have shown that lung ultrasonography may be a more clinically useful and equally accurate option for either hospitalized or ambulatory patients with suspected pneumonia, according to Kazan 2016. Advantages of this technique are its portability, operability at bedside, radiation-free exposure, and relative speed, taking an average of only 13 minutes, according to Kazan 2016, and Prina 2015. In addition, in pooled data from two meta-analyses, the sensitivity of lung ultrasonography was 0.94 to 0.95 and specificity was 0.9 to 0.96, compared with 0.77 and 0.91 for chest CT, respectively, according to Kazan 2016, Yi 2015, and Chavez 2014. Although pulse oximetry should be assessed in all patients with suspected CAP, other laboratory and microbiological evaluation depends on severity of illness. The Infectious Diseases Society of America (IDSA) guidelines, though outdated, recommend blood and sputum cultures in hospitalized patients who are critically ill or those with productive cough with failure of outpatient therapy, cavitary infiltrates, leukopenia, alcohol abuse or severe liver disease, COPD or other obstructive lung disease, asplenia, pleural effusion, or recent travel, according to Mandel 2007. Newer recommendations suggest that laboratory evaluation, including microbiology, be conducted only if the results would alter empiric antibiotic treatment, according to Kazan 2016, and Prina 2015. In patients requiring hospitalization, several tests can aid in the diagnosis of CAP. Chemistry panels, CBCs, and inflammatory markers, e.g., C-reactive protein abbreviated as CRP, may provide information regarding the severity of disease, according to Prina 2015. Cultures are helpful in consolidating definitive therapy or in patients whose therapy failed when resistance is suspected. However, cultures should be interpreted with caution because false positive cultures in patients with CAP in one study prolonged hospital stay and led to unnecessary antibiotic use, specifically with intravenous vancomycin, according to Kazan 2016. Urine antigen testing helps distinguish specific pathogens, i.e., pneumococcal disease and Legionella, particularly in patients with severe CAP. Pneumococcal urine antigen tests have a sensitivity of 60% to 80% and specificity greater than 90%, compared with 70% to 90% and 99%, respectively, for Legionella, specifically serotype 1, according to Kazan 2016. In addition, urine antigen tests are not affected by previous antibiotic use, or the inability to give an adequate sputum sample. Detection of atypical pathogens has improved in the past several years. The gold standard for diagnosis of Legionella, Mycoplasma, and Chlamydophila species is considered nucleic acid detection, and multiplex PCR has continued to make this process increasingly practical and convenient, according to Waterer 2017. Although these tests have not routinely been available historically, rapid diagnostic tests, including multiplex PCR systems, are increasingly used clinically. Pause the video and carefully scrutinize Table 1 to 4 summarizing the IDSA treatment recommendations for CAP. Next, we will discuss biomarkers for diagnosis of CAP. Use of biomarkers in conjunction with laboratory and microbiological tests for diagnosing CAP was studied recently. C-reactive protein is produced in the liver in response to pro-inflammatory cytokines, including those produced by the body in response to infection, according to Sullivan 2016. In one secondary analysis of patients with CAP, the positive and negative predictive values were 0.76 and 0.75, respectively, at the threshold of 50 mg per liter, according to Labelle 2015. Although CRP may help gauge inflammatory status, more data with this marker can be found in the septic or critically ill population. Sullivan 2016, Oliveira 2013. Procalcitonin is a precursor peptide of calcitonin that is released from thyroid and immune cells in response to bacterial toxins or inflammatory cytokines, including IL-6, IL-1 beta, and TNF-alpha, according to Schutz 2015, and Avdik 2014. Procalcitonin is primarily useful to distinguish bacterial from viral pathogens. In clinical evaluations of patients with lower respiratory tract infections, procalcitonin-guided therapy decreased antibiotic prescriptions by 42% to 75%, therapy duration by 40% to 65%, and overall antibiotic exposure by 75%, according to Schutz 2015, Avdik 2014, Schutz 2009A, and Schutz 2009B. In one meta-analysis, the 30-day mortality was unchanged compared with a control group, 5.7% versus 6.3%, respectively, with a p-value equal to 0.75, odds ratio 0.94, 0.71 to 1.23, but there was a significantly lower risk of treatment failure in the procalcitonin-guided group, 19.1% versus 21.9%, with a p-value equal to 0.02, odds ratio 0.82, 0.71 to 0.97. According to Schutz 2012. The lack of correlation to mortality may be because of the procalcitonin threshold value. Investigators found that the typical cutoff of 0.5 nanograms per milliliter was not predictive of mortality in patients with CAP, according to Liu 2016. Authors suggest that a lower threshold, less than 0.1 nanograms per milliliter, should be explored. Although use of procalcitonin in respiratory tract infections seems promising, clinicians hesitate to trust these results and often continue antibiotics despite low risk or decreasing procalcitonin scores, less than 0.1 to 0.25, depending on severity and setting, according to Buadma 2010, and Schutz 2009a. Although biomarkers may help discriminate between bacterial and viral pathogens and provide information to assist in whether to discontinue antibiotics, they are most helpful as serial markers to evaluate disease progression. Although biomarkers are usually not recommended as single tools for diagnosis, they may help in combination with other clinical and diagnostic markers, as shown in Box 1-1. In a systematic review and meta-analysis of the use of biomarkers for predicting short-term mortality, investigators pooled 24 articles and 2 databases, according to Viesis 2016. Although included biomarkers proadrenomedulin, prohormone atrial natriuretic peptide, procalcitonin, cortisol, and CRP, were moderately accurate with mortality predictions, investigators found no clear advantage over CAP-specific severity analysis scoring systems for predicting mortality. Next we will discuss severity assessment scales. Appropriate management of CAP requires ascertaining the severity of disease. 2 major scoring systems that are specific to CAP have been used to assist with severity assessment, including triage to determine whether the patient should be treated as an outpatient, inpatient, or in the ICU. The CAB-65 uses 5 parameters: confusion, urea nitrogen, respiratory rate, blood pressure, and age, to assign a score of 0 to 5 depending on the presence or absence of these features, as shown in Table 1-3, according to Prina 2015. This tool can be modified to CAB-65 to eliminate urea nitrogen in primary care settings or those where this may not be readily available. The Pneumonia Severity Index, abbreviated as PSI, has 20 items and assesses risk on the basis of comorbidities, age, and pertinent laboratory values, according to Fine 2016. The PSI has predominantly been used for research or in clinical trials. The patient care scenario describes a practical example of calculated mortality risk and providing a recommendation for therapy on the basis of this score. Although these scoring systems can be helpful clinically, both have limitations. The CAB-65 or CRB-65 is easier to use, but it does not account for comorbidities and is thus less accurate in predicting 30-day mortality, according to Kazan 2016, and Prina 2015. Sensitivity for predicting ICU admission is higher with the PSI, but it can underestimate severity in young patients or those without comorbidities, according to Kazan 2016, and Prina 2015. As a result, investigators have studied strategies to improve the accuracy and reliability of these scoring systems, according to Lee 2016b, and Fernandez 2015. In one study, the receiver operating characteristic analysis area under the curve 95% confidence interval for predicting 30-day mortality for procalcitonin 0.92, 0.85 to 1.0 was compared with the PSI 0.88, 0.78 to 0.98, CAB-65 0.88, 0.76 to 0.99, and CRB-65 0.9, 0.78 to 1 alone and in combination, according to Fernandez 2015. For all scoring systems, the combination with procalcitonin improved prognostic capabilities, increase of 8% to 65% in sensitivity and negative predictive value. In another study, assessment of additional diagnostic factors, i.e., dyspnea, high Eastern Cooperative Oncology Group performance status, and serum albumin, with CAB65 or PSI improved the accuracy in predicting 30-day mortality by 7% to 40% for specificity and positive predictive value, respectively, according to Lee 2016b. Regardless of the strategy used, assessing patient severity through techniques including validated scoring systems, biomarkers, or a combination is important in appropriate management. Studies have shown that delays in care, including appropriate antimicrobial therapy, admission to the hospital, or admission to an ICU, can negatively affect patient outcomes, according to Prina 2015, and Blasi 2014. Regarding its pharmacologic therapy, the IDSA empiric recommendations for antibiotic therapy for CAP are largely driven by severity of illness and treatment setting, i.e., outpatient versus inpatient versus ICU, which often dictate suspected pathogens, as shown in Table 1-4, according to Mandel 2007. Although the combination of a beta-lactam and a macrolide or a fluoroquinolone is equally weighted in the current guideline recommendations for patients treated as outpatients, recent evidence has suggested that fluoroquinolones provide more favorable outcomes, including incidence of treatment failure, adverse events, and treatment discontinuation, than combination therapy with a beta-lactam and a macrolide, according to Lee 2016a, and Raz Pasteur 2015. However, these results should be interpreted with caution because these studies did not compare mortality. In hospitalized patients with CAP not requiring intensive care, 2 non-inferiority trials were completed that assessed a beta-lactam alone and in combination with a macrolide, according to Postma 2015, and Garin 2014. In the first study, 2,283 patients were treated, with no difference in 90-day mortality between monotherapy and combination therapy, according to Postma 2015. In contrast, the second study trended toward the superiority of combination therapy to achieve the endpoint of clinical stability at 7 days, according to Garin 2014. Results of meta-analyses evaluating the necessity of combination therapy with a beta-lactam plus a macrolide in these patients have also varied, according to Ni 2014, Asadi 2012, and Eliakim Raz 2012. Although these data suggest that combination beta-lactam and macrolide therapy should be continued throughout therapy in hospitalized patients, discussion continues on whether this option or a fluoroquinolone is superior for empiric therapy in this setting, according to Prina 2015. In patients who require intensive care and have risk factors for Pseudomonas species e.g., COPD, or structural lung disease, previous antimicrobial therapy, or MRSA e.g. long-term dialysis use, injection drug use, previous influenza, or prior antimicrobial use, anti-pseudomonal or anti-staphylococcal coverage should be added, as shown in Table 1-4, according to Mandel 2007. Although the IDSA has recommended this treatment for CAP for the past decade, there is clinical debate on whether double or triple coverage in these critically ill patients is appropriate or necessary, according to Khalil 2016. This information will likely be revised in the upcoming CAP guidelines. Pause the video and carefully scrutinize box 1-2 comparing previous versus updated risk factors for resistant pathogens. Pause the video and carefully scrutinize Table 1-3 summarizing severity assessment predictive scores for CAP. Pause the video and carefully scrutinize Table 1-4 summarizing the IDSA treatment recommendations for CAP. Pause the video and carefully scrutinize box 1-2 comparing previous versus updated risk factors for resistant pathogens. Next we will discuss hospital-acquired pneumonia. Hospital-acquired pneumonia, abbreviated as HAP, occurs 48 hours or more after hospital admission, according to the ATS 2005. Pneumonia suspected at the time of hospital admission should be classified as CAP and is not included with the recommendations in the text that follows. In the new guidelines, HAP is further defined as pneumonia not requiring mechanical ventilation, according to Khalil 2016. Ventilator-associated pneumonia, abbreviated as VAP, in contrast, develops more than 48 to 72 hours after intubation, according to the ATS 2005. Noticeably absent in the 2016 IDSA-HAP-VAP guidelines is the terminology for healthcare-associated pneumonia, abbreviated as HCAP. Healthcare-associated pneumonia was previously included in the 2005 guidelines and was defined by the presence of increased risk of multidrug-resistant MDR pathogens on the basis of contact with the healthcare system, as shown in Box 1 to 2. According to Khalil 2016, and the ATS 2005. Since the 2005 guidelines were released, there is concern that the risk factors defined for HCAP do not truly represent a high risk of MDR pathogens, according to Khalil 2016, Chalmers 2014, Gross 2014, and Yap 2013. The HCAP classification may be redesigned and addressed in the updated CAP guidelines, according to Khalil 2016. Regarding its epidemiology and etiology, hospital-acquired pneumonia is one of the more common nosocomial infections and is responsible for morbidity and mortality of up to 30% to 70%, according to Craven 2010, and the ATS 2005. Although the all-cause mortality rate is very high, attributable mortality is difficult to determine. Hospital-acquired pneumonia is responsible for up to 25% of ICU infections and is associated with increased length of stay, hospital costs, and antibiotic use, according to Craven 2010. The presumed incidence is 5 to 10 per 1,000 hospital admissions, according to Craven 2010. Ventilator-associated pneumonia is thought to occur in 10% to 20% of ICU admissions, but this is likely underreported because of the amount of overlap with other infectious processes such as infectious tracheobronchitis in ventilated patients, according to Ottosen 2014, and the ATS 2005. Ventilator-associated pneumonia is currently not listed as a healthcare-associated infection, abbreviated as HAI by the Centers for Medicare and Medicaid Services, according to Stone 2010. With the recently reduced reimbursement structures related to other HAIs, clinicians and hospitals may hesitate to associate patients with infections acquired in hospitals, potentially furthering the underrepresentation of this disease. Causative bacterial pathogens vary in HAP and VAP. Commonly implicated pathogens include Staphylococcus aureus, Pseudomonas species, Acinetobacter species, Escherichia coli, and Klebsiella species, according to the ATS 2005. A meta-analysis conducted by the 2016 Guideline Panel found that non-glucose fermenting gram-negative bacilli were responsible for 19%, with a 95% confidence interval, 15% to 24%, of culture-positive HAP, according to Khalil 2016. Of these, 13%, 10% to 17% were Pseudomonas species, and 4%, 2% to 6% were Acinetobacter species. Enteric gram-negative bacilli were responsible for 16% of isolates, 13% to 20%. Staphylococcus aureus was isolated in 16% of cases, 12% to 21%, with MRSA representing 10%, according to Khalil 2016. In VAP, surveillance studies suggest that Staphylococcus aureus is responsible for 20% to 30% of cases, Pseudomonas aeruginosa for 10% to 20%, enteric gram-negative bacilli for 20% to 40%, and Acinetobacter baumannii for 5% to 10%, according to Khalil 2016. Resistance is increasingly common and of concern, especially with late-onset HAP greater than 96 hours, regardless of the infecting pathogen, according to Ottosson 2014. When considering resistance, of particular concern are Staphylococcus aureus infections with vancomycin or linezolid resistance, extended-spectrum beta-lactamase-producing organisms, and carbapenem-resistant Enterobacteriaceae. Regarding the pathophysiology, similar to CAP, microaspiration of colonizing pathogens is the primary route of entry into the lower respiratory tract in patients with HAP, according to Craven 2010. In VAP, oral secretions or bacteria surrounding the endotracheal site, contaminated intubation tubing, or inhalation of contaminated solutions provides routes of entry for bacteria into the lower respiratory tract. In addition, biofilms that develop in the lumen of the intubation tube impair bacterial clearance and may result in resistance over time, according to Craven 2010. Regarding the predisposing factors, risk factors for HAP include sedation, intubation for surgery, vomiting, and impaired swallowing, according to Craven 2010. Ventilator-associated pneumonia is more prevalent in patients with trauma, secondary to head trauma and decreased consciousness or chest trauma and lung injury, according to Ottosson 2014. Risk factors for resistance with HAP and VAP have been redefined and described in the 2016 IDSA guidelines, as shown in Box 1 to 2, according to Khalil 2016. Regarding the clinical presentation and diagnosis, patients with HAP or VAP typically present with 1. Temperature above 100.4 degrees Fahrenheit, that is 38 degrees Celsius, or hypothermia. 2. Leukocytosis, leukopenia, or increased immature neutrophils, and/or 3. Purulent respiratory secretions. For a diagnosis, patients should present with at least 2 of these signs and evidence of a new or progressive radiographic infiltrate, according to Craven 2010. Non-invasive respiratory sampling with semi-quantitative cultures is recommended in every patient with suspected VAP. Invasive quantitative cultures or routine blood cultures are not recommended because of unnecessary risk and increased costs, with low positive yield, according to Khalil 2016, and Craven 2010. Although some clinical data are available, biomarkers such as procalcitonin, soluble triggering receptor expressed on myeloid cells S, TREM1, and CRP are not recommended for routine use to aid in diagnosis or decide whether to initiate antibiotics, according to Khalil 2016. The Clinical Pulmonary Infection Score is a scoring system used to identify the presence of clinical pneumonia that assigns points for clinical, radiological, physiological, and microbiological data, according to Craven 2010. Although this score has been used clinically, it is no longer recommended for deciding whether to initiate antibiotic therapy, according to Khalil 2016. Regarding pharmacologic therapy, the IDSA Clinical Practice Guidelines for HAP and VAP were updated in 2016, according to Khalil 2016. In contrast to CAP, in which empiric therapy is similar across institutions because the pathogens are generally the same, the new guidelines for HAP and VAP recommend an individualized, hospital-directed approach, according to Khalil 2016. The 2016 guidelines recommend that every hospital generate and distribute a local antibiogram and, more specifically, that these antibiograms integrate ICU-specific data, according to Khalil 2016. Pathogens associated with HAP and VAP vary, and the resistance patterns of these responsible pathogens differ by region. Thus, it is important to assemble local susceptibility data to assist with clinical decision-making. Regarding hospital-acquired pneumonia, for HAP, the 2016 IDSA guidelines recommend empiric therapy, given the risk of mortality and the risk of MRSA or Pseudomonas aeruginosa, as shown in Table 1-5, according to Khalil 2016. Therapy targeting MRSA, vancomycin or linezolid, is recommended only if the patient has risk factors for MRSA, as shown in box 1-2. Without specific risk factors for MRSA, suggested agents that will provide appropriate coverage for methicillin-susceptible Staphylococcus aureus, that is MSSA, include piperacillin, tazobactam, cefepime, levofloxacin, imipenem, C-lastatin, and meropenem, according to Khalil 2016. Local antibiograms may be used to guide selection of empiric therapy. Therapy duration for HAP should be 7 days unless patient characteristics or poor clinical response necessitates a longer course. Next we will discuss ventilator-associated pneumonia, abbreviated as VAP. Treatment options for VAP are similar to those for HAP, as shown in Table 1-5. Coverage for MRSA should be provided only in patients at risk, otherwise, MSSA coverage should be sufficient, according to Khalil 2016. Double gram-negative coverage, including a beta-lactam anti-pseudomonal agent plus a non-beta-lactam anti-pseudomonal agent, is recommended if the patient has risk factors for Pseudomonas species or other MDR gram-negative organisms. Monotherapy with an agent that covers MSSA and Pseudomonas aeruginosa may be sufficient in patients with no significant risk factors for resistance, according to Khalil 2016. Next we will discuss treatment of resistant pathogens. Although the carbapenems are broader spectrum than other recommended agents, the guidelines do not specify that carbapenems should be selected as first-line options over any other choices, according to Khalil 2016. However, in some clinical situations, carbapenems should be used as first-line agents. Extended-spectrum beta-lactamases, according to the CDC, are enzymes that confer resistance to extended-spectrum cephalosporins, that is third-generation agents, and aztreonam, according to the CDC 2010. In a meta-analysis of 1584 patients with extended-spectrum beta-lactamase-producing organisms, carbapenem monotherapy was associated with lower mortality than non-beta-lactam, beta-lactamase inhibitor combinations R 0.65, 0.47 to 0.91. However, mortality between carbapenems and beta-lactam, beta-lactamase inhibitors did not differ R 0.52, 0.23 to 1.13 when used as definitive or empiric therapy, according to Vardakas 2012. In contrast, beta-lactam, beta-lactamase inhibitors were no different from non-beta-lactam, beta-lactamase inhibitors. Of note, however, in many of the included studies, patients who received beta-lactam, beta-lactamase inhibitor combinations empirically went on to receive carbapenems as definitive therapy, which may confound these results and provide an explanation for the similar mortality between these groups. Recent studies of the role of beta-lactam, beta-lactamase inhibitors in this setting have been promising. The role of piperacillin, tazobactam seems limited to infections stemming from the urinary or biliary tract or those with low MICs. When recommending piperacillin, tazobactam in this setting, high-dose therapy, 4.5 grams every 6 hours should be used, according to Yoon 2017 and Rodriguez-Bano 2012. Despite these results, carbapenems are usually still considered the treatment of choice for these infections, according to Tama 2015, and Vardakas 2012. In patients infected with carbapenem-resistant organisms, clinical decisions related to appropriate therapeutic options can be difficult. Colistin or polymyxin B may be considered in patients with resistance to or inability to take or tolerate other available antimicrobial options, according to Khalil 2016. Similar to aminoglycosides, the risks of adverse events with either agent plus the risk of increased resistance with overuse should be considered with each clinical use of a polymyxin, according to Khalil 2016. In infections caused by organisms that are susceptible only to the polymyxins, i.e., Acinetobacter species, adjunctive inhaled colistin should be considered with intravenous therapy. In addition to the therapeutic options listed earlier, ceftazidime, avibactam, ceftolozane, tazobactam, and meropenem, vabibactam are advanced-generation cephalosporin and carbapenem combinations with expanded spectrums against gram-negative pathogens, according to Wright 2017, and Van Duyn 2016. Although these agents are currently only approved for complicated intra-abdominal infections and/or complicated UTIs, the in vitro susceptibilities of these agents to resistant pathogens, including extended-spectrum beta-lactamus, and carbapenem-resistant Enterobacteriaceae-producing organisms, make them attractive new options, according to Wright 2017, and Van Duyn 2016. In fact, several studies are underway for their use in the treatment of pneumonia. A clinical trial of ceftolozane, tazobactam has been completed in patients with cystic fibrosis. Trials evaluating the lung penetration of ceftolozane, tazobactam in pneumonia and the safety and efficacy of ceftolozane, tazobactam for VAP are currently under recruitment, according to Kuti 2017, Cubist Pharmaceuticals 2017 A, Cubist Pharmaceuticals 2017b. A trial comparing ceftolozane, tazobactam 3 grams intravenously every 8 hours with piperacillin, tazobactam 4.5 grams intravenously every 8 hours for VAP was terminated early by the manufacturer to focus on a larger VAP trial, according to Cubist Pharmaceuticals 2017c. For ceftazidime, avibactam, a trial evaluating 2.5 grams intravenously every 8 hours in patients with cystic fibrosis has been completed and results are pending, according to the USC 2017. In a trial comparing ceftazidime, avibactam 2.5 grams intravenously with meropenem 1 gram intravenously for HAP, patients were recruited from April 2013 to January 2016, and 808 patients were analyzed, 405 ceftazidime, avibactam and 403 meropenem, according to AstraZeneca 2017. The primary endpoint was clinical cure at the test of cure visit days 21 to 25. In the modified intention to treat population, clinical cure occurred in 245 patients receiving ceftazidime, avibactam compared with 270 receiving meropenem, with a p-value equal to 0.007, negative 4.2, that is negative 10.76 to 2.46. Non-inferiority of ceftazidime, avibactam was determined if the lower end of the 95% confidence interval was greater than negative 12.5%, according to AstraZeneca 2017. Because the results met the negative 12.5% threshold, ceftazidime, avibactam was determined to be non-inferior to meropenem. In the clinically evaluable population, clinical cure occurred in 199 versus 211 patients, respectively, with a p-value less than 0.001, negative 0.7, that is negative 7.86 to 6.39. A clinical trial comparing meropenem, avibactam with best available therapy for serious infections caused by carbapenem-resistant Enterobacteriaceae was terminated early as a result of improved clinical cure rates and reduced adverse events versus comparators, according to a release from the manufacturer, according to Medicines Company 2017b, and Medicines Company 2017c. A clinical trial NCT 03006679 comparing meropenem, avibactam with piperacillin, tazobactam for HAP and ventilator-associated bacterial pneumonia is planned, but recruitment has not yet begun, according to Medicines Company 2017a. No official statement has been made regarding the place in therapy with these advanced generation cephalosporin and carbapenem combination agents because information was lacking at the time of the guidelines. However, given the promise of coverage for MDR pathogens and the initial results from clinical trials, these agents may represent therapeutic options in challenging cases without sufficient alternatives. Regarding therapy duration for HAP or VAP should be 7 days unless the patient has a poor clinical response and requires a longer course, according to Khalil 2016. One of the first studies evaluating therapy duration was done in 2003, in which investigators found similar results in 8 to 15 days of therapy in VAP, according to Chasta 2003. In a subsequent systematic review, 7 to 8 days of antibiotics increased 28-day antibiotic-free days, mean 4.02 days, that is 2.26 to 5.78, and reduced recurrent VAP caused by MDR pathogens, 42.1% versus 62.3%, OR 0.44, that is 0.21 to 0.95, compared with longer courses, according to Khalil 2016. Pause the video and carefully scrutinize Table 1 to 5 summarizing IDSA recommendations for empiric therapy for HAP and VAP. Pause the video and carefully scrutinize Table 1 to 5 summarizing IDSA recommendations for empiric therapy for HAP and VAP. Next we will discuss its prevention. The hallmark of prevention for lower respiratory tract infections is immunization. All patients are recommended to receive the influenza vaccination every year, according to the CDC 2017. Although a live attenuated influenza vaccine, abbreviated as LAIV, is available for nasal administration, many contraindications exist. For both the 2016 to 2017 and the 2017 to 2018 influenza seasons, the Advisory Committee on Immunization Practices recommended that LAIV be avoided because of poor or relatively lower effectiveness compared with other influenza vaccines over the past several years, according to the CDC 2017. Instead, patients should receive the inactivated or recombinant influenza vaccine. Administration of the influenza vaccine has been associated with about a 30% reduced incidence of pneumonia and an overall reduction in the risk of all-cause mortality of up to 50%, according to Mandel 2007. 2 vaccines are available for the prevention of pneumococcal disease. The pneumococcal polysaccharide vaccine, abbreviated as PPSV23, provides protection against 23 serotypes of Streptococcus pneumoniae and has traditionally been recommended for patients older than 65 and patients with high-risk disease, according to Mandel 2007. The pneumococcal conjugate vaccine, abbreviated as PCV13, provides protection against 13 serotypes of Streptococcus pneumoniae and should be administered in a series of 4 doses to children, according to the CDC 2017. In addition, adults 65 and older who have not received PCV13 should receive 1 dose of PCV13 followed by PPSV23 1 year later. If patients have already received at least one dose of PPSV23, PCV13 should be given at least 1 year after the most recent pneumococcal vaccine, according to the CDC 2017. PCV13 is thought to induce a stronger immune response, providing longer-lasting protection, but patients are still recommended to receive the PPSV23 also because it protects against additional pneumococcal serotypes, according to PRENA 2015. Patients with weakened immune systems or asthenia should receive both pneumococcal vaccines to protect against pneumococcal diseases, according to the CDC 2017. In patients with spleen removal, vaccines should be given 14 days before surgery, if possible, or as soon as possible once stabilized after surgery. In hospitalized patients, several strategies may help prevent HAP and VAP, including infection control and prevention, hand hygiene and microbial surveillance, antimicrobial stewardship, prevention of aspiration, avoidance of supine position, sedation with awakening trials, and avoidance of aspiration of secretions with intubation, according to Ottosen 2014, and Craven 2010. We will now discuss the role of antimicrobial stewardship programs. Antimicrobial stewardship programs, abbreviated as ASPs, may play a role by providing education on common viral illnesses, as well as methods to appropriately handle patient requests for antibiotics in these situations. Clinicians, in turn, should be prepared to educate patients. In patients with suspected bronchitis, many strategies have been suggested to reduce unnecessary antibiotic use, including compassionate patient care, explanation of the disease process and expectations, delayed prescription strategies, and non-antibiotic therapies, according to Kincaid 2016. In CAP, ASPs can play a valuable role by providing microbiological follow-up and narrowing of antibiotic therapy, according to PRENA 2015. In addition, ASPs or clinical pharmacists may play a role in risk and severity assessment, renal dosage adjustments, recommendations on intravenous to oral antibiotic changes, and/or follow-up at the end of the treatment period to ensure that antibiotics are discontinued as appropriate, which may help avoid unnecessary hospital costs. In one clinical evaluation, a stewardship intervention on patients with CAP regarding antibiotic choice and duration reduced the duration of antimicrobial therapy from 10 days to 7 days with a p-value less than 0.001, and increased the number of antibiotics narrowed or modified on the basis of susceptibility, 67% versus 19% in the control period, according to AVDIC 2012. In another evaluation, an ASP prospective audit and feedback intervention on hospitalized patients with CAP resulted in a non-significant reduction in length of stay 11%, that is, -9% to 35%, and reduced time to antibiotic discontinuation by 29%, 10% to 52%, with no change in 30-day readmissions or all-cause mortality 0.79. With a 95% confidence interval of 0.49 to 1.29, according to Diodato 2016. In HAP or VAP, a large emphasis should be placed on ASP participation in creating unit-specific antibiograms, proper hygiene measures to prevent the spread of infection, including hand hygiene, microbiological surveillance and follow-up, and subsequent de-escalation, as appropriate, according to Khalil 2016. In addition, procalcitonin is recommended in combination with clinical criteria as a tool to assist in determining when to discontinue antibiotics, according to Khalil 2016. Regardless of the type of lower respiratory tract infection, antimicrobial stewardship provides a valuable service in reducing unnecessary antimicrobial use, subsequently preventing the development of resistance and improving patient outcomes. Lastly, we will look at some practice points. Lower respiratory tract infections are a common cause of infection in both inpatients and outpatients. New data continue to emerge on how best to address these infections. As a result, guidelines and recommendations continue to evolve. 1. Acute bronchitis is caused by viral pathogens in 90% of cases and is often self-limited. Treatment with antibiotics is not recommended unless the patient is at high risk of pneumonia. 2. CAP disproportionately affects the young, younger than 5 years, and old, older than 65 years. Management depends on patient risk factors, severity of illness, and healthcare exposure. 3. Severity of illness and risk of mortality in CAP should be assessed using a combination of a severity score such as the CAB-65 or PSI and clinical signs and symptoms, and the patient should be treated in a unit according to disease severity. 4. IDSA recently updated its guidelines for managing HAP and VAP. HCAP was the terminology previously used to account for exposure to the healthcare system. However, exposure to healthcare is not believed to be an accurate representation of the risk of multidrug resistance, hence, this terminology has been removed from the updated guidelines. In addition, risk factors for multidrug resistance, MRSA, and Pseudomonas species have been updated. 5. Biomarkers such as procalcitonin and CRP in patients with pneumonia may aid in decisions regarding antibiotic discontinuation, but they are less helpful when used to decide whether to initiate antibiotics. 6. Novel therapies, including ceftolozane, tazobactam and ceftazidime, avibactam, provide additional ammunition against resistant gram-negative pathogens, but these have not yet been sufficiently studied in pneumonia to make a firm recommendation for use. 7. Prevention of pneumonia should include immunizations, influenza and pneumococcal, as appropriate, and infection control strategies such as hand hygiene. 8. Antimicrobial stewardship is increasingly important and stressed in these updated guidelines. Roles include preventing unnecessary antibiotic use, performing microbial surveillance and response, and providing education to prescribers regarding appropriate therapy and duration.